Okay, Renee, it's 4 o'clock. I'd like to call this meeting to order. It looks like most of the board members are here except for Jan, and hopefully she'll be joining us shortly. Could you do the roll call for me, please?
Yes. When I call your name, please state present. Representing the Board of Health on Adams County, Julie Mollica.
Present.
Rosanna Reyes.
Present.
Julie Shills.
Present.
Representing Arapahoe County on the Board of Health, Jan Brainerd.
Present.
Dr. Thomas Faywell.
Present.
Dr. Kaya Gallagher.
Present.
Representing Douglas County on the Board of Health, Kevin Bracken.
Present.
Dr. Linda Fielding.
Present.
Kim Muramoto. I will now do roll call for Tri-County Health Department leadership. Michelle Askenazi, Director of Emergency Preparedness, Response, and Communicable Disease Surveillance.
Present.
Heather Baumgartner.
Recording in progress.
All of the Board of Health members who made time this afternoon for this important meeting. So over the last 2 weeks, many of us have received emails from parents, both who are in favor of mask mandates as well as those who are opposed. And as part of those email correspondences, many requested that we examine the data to determine whether to continue this policy. So tonight, Dr. Douglas will be presenting the latest information regarding the COVID pandemic within our 3 counties. This information was shared with the Board of Health on Saturday as draft slides. The Board of Health will also consider whether our current policies need to be changed. Before we begin, we've had a request to follow Robert's Rules of Order. So these are the guidelines that we are going to be following tonight. In the event that a motion is put forward and then seconded, we will then open the floor for comments from the Board of Health. To assure that all comments, all opinions are heard, I will call on each Board of Health member to speak if he or she chooses. In the interest of hearing from everyone, we will limit comments to 3 minutes. Lisa will serve as our timekeeper and will warn each Board of Health member when 30 seconds is approaching and their time is almost up. Once all the board members have had a chance to speak, we'll open the floor for a second round of comments. As before, Board of Health members will be given a chance to speak for another 3 minutes. According to Robert's Rules of Order, Board of Health members will only have 2 opportunities to express their views. So with that, we are going to be moving now to Dr. Douglas's update on COVID trends in schools.
Thank you, Dr. Gallagher. I'm going to be assisted by Lisa Bolstad, who's going to advance the slides. While she's pulling them up, Kevin, let me just give you a personal welcome. We've had lots of interactions with you over the past year, and I think Douglas County's picked a knowledgeable member. So welcome aboard. Next slide, please, Lisa. So I want to cover 4 topics. An update on trends, as Kaya said, with a particular focus on school-age kids. Provide an updated summary on the benefits of masking. This is something we've covered before, but I want to try to do it in perhaps a better summary than we've done before, because obviously, as Kaya mentioned, this is an issue around which there's lots of interest in the community, and I want to be sure the board is sort of comprehensively up to speed. I'd like to then address, as we posted on the agenda, a reconsideration of our current opt-out policy, and then finally, a reconsideration of school mask mandates, given where we stand right now. Let's move to the next slide, please, Lisa. That's another filler. So the next slide. Okay, so Delta variant 101. I think you guys know this, but let's just sort of get it out there. I think we're all aware this is part of a new nomenclature. You refer to things by the genetic typing numerology. This is B.1.617.2, but now we call it Delta. First showed up in India, now worldwide. It's got a number of related subvariants. These have just recently begun to be plotted on the Colorado variant chart, which is on the right side. This is AY1, AY2, and AY3. We do not yet know if these have got different functionalities. They do appear to be likely similar to Delta in terms of transmissibility, but they're still really being characterized. Key point, twice as contagious, really about 2.25 times as contagious as the strain from last winter, the original Wuhan strain. And increasing data says that it's approximately twice as severe. Data from a number of different places, including a report that came in from Lancet Infectious Diseases yesterday or Saturday, I guess, 40,000 some odd patients in Britain. Looks like similarly about twice as severe in terms of hospitalization. It's now the vast majority of cases in Colorado, especially if you add in the AY1, 2, 3. Colorado continues to rank very highly, although frankly, across the country, most strains that are circulating now per CDC measurements are Delta. Again, we will continue to be observant about future mutations. Chatter a couple of weeks ago about Delta Plus. That's still being characterized, not yet been deemed or termed a quote variant of concern. And as I know the board knows, but I just want to be sure everybody listening knows, vaccines work. Best data on the Pfizer vaccine, but probably the Moderna vaccine. Both doses required. With both doses, you get probably mid 80% protection against severe infection, but you get less protection against milder or asymptomatic infection. That's probably down in the mid 70s. And the big news from last month, based on the analysis of the outbreak in Provincetown, is that those vaccinated who do get infected are as contagious as determined by viral load assessment of cycle time from positive samples as people that are unvaccinated. That sort of ended up being the big question. If you're in a tight setting and you've been vaccinated, you could have an asymptomatic infection and you could transmit. So I know the board knows that, but I just wanted to be sure we were all kind of on the same page. Next slide, please, Lisa. So, and we talked about this, but I just thought it was worth looking. This is data that was initially, I put shared by the Washington Post. I'm not sure the CDC's ever released it. It was an internal CDC presentation. But following Dr. Walensky's announcement about the Provincetown outbreak on Tuesday, the 27th of July, this presentation became widely circulated. And this, really, the purpose of this is to sort of give you some flavor for the relative transmissibility of the SARS-CoV-2 Delta variant. It's kind of got a wide estimation of the R0 value. That's the x-axis there, the number of people infected by each sick person. But the key point of this observation was that when we compare it certainly to the ancestral strain, in the pink, it's more contagious. And when we think back to common infectious diseases we've dealt with, including things like bird flu, Ebola, Spanish influenza from 1918-19, smallpox, et cetera, this is a more transmissible strain, really only exceeded in the estimations of most infectious disease experts by chickenpox and measles. Next slide, please. This is that report of the outbreak from Barnstable County, Provincetown, that happened over the July 4th weekend. And I know that you all are aware of this, but I just thought it was worth sort of laying it out there. This was an outbreak that actually, in the initial MMWR report, had 469 cases. The majority in the light blue on the histogram were actually fully vaccinated, with the smaller number being unvaccinated. The key figure is the one on the right, which looks at the cycle threshold value, the CT value. And as you can see, the CT threshold values for the folks that were unvaccinated versus those who were fully vaccinated were really highly overlapping, which was the basis of the observation that once infected post-vaccination with Delta, you may be as contagious to other people as somebody who's totally unvaccinated. Next slide, please, Lisa. And this is a quick synopsis of data. This is sort of a snip from that CDC Washington Post shared presentation. This was, again, about 3.5 weeks ago. Data from Canada, higher odds of hospitalization, adjusted odds ratio 2.2, ICU admission 3.87, death 2.37. Singapore study, slightly different outcomes. Composite oxygen requirement, ICU admission or death, adjusted odds ratio 4.9, pneumonia adjusted odds ratio 1.88. Smaller study from Scotland looked just at hospitalization, hazard ratio of 1.85, sort of in the same range, if you will, of what the other studies demonstrated. The tables to the right show some of that data. The key comparison in the Singapore study was comparing the Delta outcomes to the Beta and the Alpha strain outcomes. They did a very limited age stratification, and that's part of the reason I included it here, because lots of questions have come up about what about Delta in kids? And the answer is none of the studies have addressed Delta in kids. They haven't stratified it sufficiently. You can see, of course, here that the older you are in the Singapore study, just in this 3-part bifurcation with less than 45 being the referent group, 45 to 64, if you focus just on the multivariate adjusted odds ratio, much higher rates, 6.6, and in those even older, greater than 65, even higher, 13.8. I didn't put the Lancet infectious disease piece in here, but its hazard ratios, once adjusted for a number of different variables, falls in the mix of what we see here, about 2.2 increased rates of severe outcomes with Delta versus, in that case, comparing it to Alpha. Next slide, please. So this is looking at what's happening with cases in kids. Now, these are cases. These are not severe illnesses. These are rates of infection. This is Colorado data from last week from Dr. Hurley, state epidemiologist. And your referent group, if you will, here is 18 plus, the red line. And as you can see, the 6 to 11 group over the past couple of weeks had begun to move higher. This is a 7-day moving average per 1,000 people. These are not raw numbers, but rates. With your 12 to 17 group sort of being not as high yet as the 18 plus, but moving up. And while the 0 to 5 group had increased substantially since early July, it was the lowest of the 4 categories that Dr. Hurley looked at. Next slide, please. Bernadette and team did a similar analysis for the Tri-County area cases. And this just came in today. So for the board members who had a chance to look at the draft slides I sent, this was not in them. Color code again, 0 to 5 is blue. Yellow is 6 to 11 years old. Red is 12 to 17, and 18 plus is turquoise. So once again, the 6 to 11 group has really shot up fast and is now across our 3 counties, the highest rate of any of those 4 age broken out groups. The 12 to 17-year-old group has now also moved into, if you will, second place compared to the 18 plus year old reference group. Fortunately, the 0 to 5 is still lagging behind. My interpretation of these data are that our 12 to 17-year-olds are about 50% vaccinated. they probably have enough protection to keep their rates from going higher. I think our 0 to 5s probably have less contact in settings such as schools, even though some clearly go to child care centers. Next slide, please. And this is looking at a sort of a companion measure, the percent positivity. Remember, we've been following percent positivity to assess the speed of expansion of the epidemic. Is transmission increasing, or is testing sufficient? And we've, historically used, per CDC and WHO recommendations, 5% as a threshold to say we're probably doing enough testing. So once again, the same 4 age groups. And as you can see, we got really to a very low point in early June, below about 3%. We began to go up in late June and July, and then we've gone up fairly substantially since then. Once again, the 6 to 11 groups with a current estimation of around 11 to 12% being the highest, again, far above the 5%, implying lots of transmission. And similarly, our 12 to 17-year-olds and our 0 to 5-year-olds are substantially above 5%, somewhere around 7.5%, 8% at this point. Even our 18-plus-year-olds are above the 5%, but they, at least from a test positivity perspective, are the lowest group at around 6.5% to 7%. So what does all that mean? It means rates are going up. This corroborates that. And it says they may be going up even faster than we're measuring, because test positivity above 5% suggests we may not be capturing everybody who's actively infected. Next slide, please. This is a way of wrapping up the percent change in the incidence rates by age in our area over the past 4 weeks. This was put together last week. So if we go to the upper left-hand corner, let's just go by age group. 0 to 4, 4-week increase, 90%. 5 to 10-year-olds, 127%. 11 to 14-year-olds, 79%, et cetera. Those groups are going up as fast or faster than any group, which was confirmed by or rather supported by the data I've already shown you. And there are some differences between counties, but the increases, particularly in the 5 to 10 and the 11 to 14 group, are all quite high in all 3 counties. So again, some distinction, but the major message appears to be the same, whether you look at it as a 3-county jurisdiction or break it down by individual county. Next slide, please, Lisa. Now, we've all been interested in what does all this mean for in-person learning? And one of the best metrics we have of what does this mean for in-person learning is what's happening with school outbreaks. So these are the weekly tabulations of outbreaks since the first week of August. Total outbreaks in blue, confirmed outbreaks in orange, and suspect outbreaks in gray. To be a confirmed outbreak, you need to have at least 5 people with confirmed infection. To be a suspect outbreak, you need 5 people, one of whom has a confirmed infection, and the other 4 have symptomatic illness compatible with COVID that's currently being tested. Most of, thus far, the confirmed outbreaks have actually evolved into suspected outbreaks. Sorry, the other way around. Most of the suspectives have evolved into confirmed. So I don't want to say for sure that everything in gray will be confirmed by next week, but at least that's been the trend so far. That totals up to, by the way, 39 outbreaks, cumulatively speaking, over the first 26 days of August as of last Friday. As of this morning, we have 5 more outbreaks, 19 confirmed and 25 suspect. The confirms over and above the ones on Friday were ones that were suspect. So that growth pattern over the weekend of about, 5 out of 39, maybe a 10% or so increase over a short period of time. Now, I'm hoping that's going to be modulated, because even though the mask mandate that the board passed a couple of weeks ago has been opted out of by Adams County and opted out of by Douglas County, fortunately, the school districts have, at least for the age group that we recommended, been implementing their own masking policies. And I suspect that may begin to show an effect. Those didn't really take place for the most part until Monday, the 23rd, which is when our order went into effect. And because we're only a week after that, and you probably really need to get a positive test for somebody who gets infected, you're really talking 7 to 10 days, even with a more rapidly incubating infection. And then to get up to enough of a cluster of cases to have an outbreak, to measure it, you're probably talking another 7 days. So just be aware that outbreaks that may be incubating now and happening are probably going to take 14, 17 days to manifest themselves. Next slide, please. This breaks down the outbreaks. Again, there's 39 as of Friday by county and by level of school. We had seen the most outbreaks going to the first column in Douglas County, 22, involving a total of 92 cases. Next in Arapahoe, a total of 52 cases. And least at that point in time, Adams County, 5 with 25 cases. As you can see, they are occurring at different levels. No high school, middle school in Adams yet, mostly elementary and 1K through 12. We do have 3 high school, middle schools in Arapahoe. Again, predominance of elementary, but we've also got some K through 12 and K through 8 schools involved. And then finally in Douglas, it's actually a predominance of high schools and middle schools, 12, with the others being either elementary, ESC, or those with larger groupings. Next slide, please. Now, fortunately, so far, we have seen fewer child care center outbreaks. This is covering the same time period. Confirmed outbreaks in the top, we've had 5 across the 3 counties. And suspect outbreaks, we've had 4. So that's a total of 9. Less than we're seeing in the schools. I think the greatest likelihood is the fact that the younger kids, as you saw in the earlier data, have lower prevalences of infection. So we're probably at least currently bringing together fewer folks with the higher case rates and test positivities. It may also be because the younger kids are less likely, thank goodness, to get sick and develop symptoms, and they may not simply be being detected and being registered as cases. I don't have a trend line to show you for this, but the trend has been somewhat similar over the last 4 weeks, increasing roughly similarly to the school outbreaks. Next slide, please. Now, this is the one geo-focused slide I'm going to show you, and this is a map that we've posted on our website that looks at rates of infection by census tract, and I want to be sure you understand the legend. These are 2-week cumulative incidence rates per 100,000. We've color-coded them to be analogous to what CDC color codes its transmission rate categories by. They consider 7-day rates of greater than 100 to be high transmission. Because we're measuring things right now in 2-week intervals, we use 200. They consider a substantial area of transmission, which they also code as orange, for a 1-week period to be greater than 50. And that's why we simply doubled that to give us the threshold for what we're measuring in 2 weeks. And then finally, we've got 2 lighter shades, which right now are really not being seen in any of our counties. Key messages here is that most parts of our counties, really the one major exception is Western Douglas County, is in a high rate of transmission. And one slice in the middle, I'm actually not sure, my Douglas County's geography is not as good as it should be. I'm not sure which area that is, but for the most part, again, high rates of transmission. One thing I particularly wanted to point out for our Adams and Arapahoe board members is that the easternmost parts of those 2 counties, which actually are, of course, more sparsely populated, that census tract in Adams County being called Northeast Adams, and that census tract in Arapahoe County being called East Arapahoe, have got on the dashboard to the right, which if you scroll down it, this is a screenshot, will give you rate information on all 306 census tracts in our 3 counties. Northeast Adams has the 3rd highest rate as of last, I think this was Friday, or maybe this was Saturday. And East Arapahoe, again, this is out of 300 some odd plus census tracts, had the 12th highest rates. So while there are relatively few cases in the rural parts of the counties, and of course, the majority of the absolute number of cases are in the western parts of the counties, the rates, how heavily impacted the county, the census tracts are when one adjusts it for population, is in fact quite high. Next slide, please. So this is really tiny data, but I know you've been interested in, well, how does this stuff look by school district? So here we have 14 of our 15 school districts, and the one we don't show is Deer Trail in eastern Arapahoe County, and we don't show it because in the most recent week, 2 weeks, I think we didn't have any cases, and the way this spreadsheet was set up, it doesn't portray it. So we're not forgetting Deer Trail, but at least right now, there are relatively few cases happening out there. But I want to walk down and maybe focus on the last column, which is the most recent week. And the way this is set up is number of cases diagnosed in that, or rather reported during that week, and the rate per 10,000, not per 100,000. So, kind of mentally translate, multiply times 10 to kind of get back to where I was showing you before. So Adams 12, Eastern Adams County, a rate of 15 per 10,000. Adams 14, a rate of 11 per 10,000. And what the red circles mean are those that had universal mask mandates by district policy in place since the beginning of the school year. Adams Arapahoe 28J is Aurora Public Schools 12.8. Bennett, one of our rural districts, substantially higher, 64.8. No cases in Byers this past week, but the previous week, again, small number of cases was similar. Some of the western counties were a little higher, 17.4. Cherry Creek moving down the list, 13.3. Douglas County, 20. Inglewood, mask mandate, lower rate, 8. Littleton, next door to Inglewood, rate of 14.5. Mapleton, Adams County, no mask mandate, and fortunately a fairly low rate at this point, although a fairly small number of students, so it does vary week by week. 27J is in Brighton, sort of a mid-range rate of 37. Sheridan, mask mandate, lower rate, 16.7. Strasburg, another of our Eastern Plains districts, substantially higher rate, even though fairly small number of kids, close to 90. And Westminster, mask mandate, kind of a middle range, 18.9. So this is just an eyeball observation that there seems to be, but this could easily change over time, a lower rate among those districts that have had mask mandates. But I just mostly wanted to give you a flavor because some of you know one school district better than another, and I wanted to be sure you understand granularly how that looked. Next slide, please, Lisa. This is state data showing you trends in hospitalizations, and two messages here. As of about a week ago, this is a rolling 7-day average, that red line. And as of about a week ago, we were higher than we had been in what some have been calling Colorado's fourth wave. You're going to hear references to waves, and the first was in April, and the second was last July, and the third one was the killer last December. The fourth was in the springtime, and now we're in our fifth wave. But the hospitalizations did get higher than the fourth wave, but certainly not as high as the fifth wave, or the third wave, rather. It looks like we might be going down, which is really good news. Cautionary note, though, is that hospital rates, even rolling 7-day averages, can vary a lot. We've realized, for example, as we've started posting our own rates, that we don't get complete hospitalization data for about a month or so after the date of admission. By a week after admission of the day of admission, we've captured about 30 to 40%. By 2 weeks, we've captured about 75%. So hospitalizations are a really critical metric to follow, but they do have a lag built into them. Next slide, please. These are looking at hospitalizations by age group. Once again, this is Colorado data from Dr. Herlihy. Left graph here shows you the higher age group, 18 plus. And, you know, the visual tells it all, really, that 18 plus has far higher rates of hospitalization. Or these are actually numbers of people, not rates. far higher numbers than do the lower age groups, 0 to 5, 6 to 11, 12 to 17. Because the lower age groups are so hard to see, Dr. Hurley broke them out on the right. And there are clearly hospitalizations happening, but they are really much, much less common thus far than what we see with older people. Now, I do want to, again, a cautionary note circled in red down there. The data, Dr. Hurley, he considers it's best to consider it lagged by 2 weeks because of the delay in capturing hospital data. So we don't really yet know if these are going to go up as they appear to be going up, again, at a very small level. I don't want to overemphasize that. Sorry, Lisa, go back. Or whether because of this 2-week lag, they will continue to rise. Now, Lisa, we can go forward. Lisa's helping me because I can't walk and chew gum. This is looking at overall rates of hospitalizations in Tri-County, looking at hospitalization rates per 100,000. This is everybody. So that's why the rates appear to be higher, because we've got the older people pulled in. I think the major message here is that in our counties, just like in the state, since the halcyon days of late June, we thought it was all over, things have gone up by about 2.5-fold, with roughly similar increases in all 3 counties. Mid-August, Adams was a little higher than the others. About a week ago, Douglas was a little higher than the others. Beware of that apparent decline in the gray area. It could be real, but it could be lagging hospitalizations. So just want to give you a flavor for what it looks like in our district. Next slide, please. And then this is our age breakout. We've got it broken out a little more granularly, 75 plus, 65 to 74, those in turquoise and red respectively, yellow 45 to 64, blue 18 to 44, and then very low, just like it is in the state data, the green representing those less than 18. I think the major message here is that the biggest increase has not surprisingly been in the most vulnerable. Many of those folks are vaccinated. It looks like currently that in that age group, about 75% of the hospitalizations are occurring in unvaccinated people, but there are some breakthroughs beginning to happen. And those people got vaccinated earlier. And because we now are beginning to think boosters are going to be needed soon, they either may be more fragile or they may begin to have waning immunity. And that's probably what's going on with them. Next slide, please. I just want to, again, I'm not trying to wave red flags or whatnot, but I just want to say that we are trying to watch signals happening from other parts of the country. Larimer County just announced on the right Friday that their hospitals had hit their max ICU capacity. At least thus far, ours appear to be in better shape. New Orleans, and this is of course pre-Ida, was experiencing a major increase. We've heard similar reports from pediatric hospitals in the southern parts of the country. I just heard from a colleague that pediatric ICU beds in Dallas, for example, became full over the weekend. And I think what's really going on here is whether Delta is more serious in children than it is in adults, or than it used to be, or whether this is simply more kids getting infected, we'll see more serious outcomes. Even with a relatively constant rate of severity, what is again being shown in these other places, and I think we may be vulnerable to this because our young kids are no better vaccinated than kids in Dallas or Jackson, Mississippi, or New Orleans. They're not eligible for the vaccine yet. And so that, even if it turns, is not something that is going to be proportion severity-wise, simply absolute number-wise. It is something our pediatric hospital colleagues are watching quite closely. Next slide, please. And this is, in fact, at least as of last, I guess this was Saturday, an estimation by region about ICU bed availability. Larimer's in the Northeast, they were having the greatest trouble. Our region, the Mile High, we're somewhat better off, about 20% of beds available. Just to the south of us, including El Paso County, a little more challenging, 9%. So you see it varies a fair amount across the state. And then I've included a dashboard that's been on our website for the last year, looking at the fullness of ICU beds and the current capacity. This was as of, I think, Saturday as well. So 11% free in Adams, 15% in Arapahoe, and at least right now, Douglas has the most, 20%. Bearing in mind that hospitals don't just admit patients from their counties. A county doesn't, if you will, own the capacity of a hospital, and folks get transferred as need arises. In fact, the state just set up reinstituted its transfer center protocol on Friday because of some of the early warnings of concern from hospital folks. We're not full yet, but we want to be prepared. So this is a snapshot of where we stand regionally as well as by county as of Saturday. Next slide, please. And I've referred to vaccines, and I've most of our board meetings, of course, given you a detailed vaccine update, but I just want to point to the what's happened over the past 2.5 weeks, from 8/11 to 8/26 in terms of vaccination. I've circled the school age groups. So we've gone up for each of the 12 to 15 by county and 16 to 17 by county, about 3 to 5% or so. So we're making progress. We're getting higher rates of vaccination, but we still have got, even the best of circumstances, 16 to 17-year-olds in Douglas County, 63% are fully vaccinated, which again is the number we need to be focused on, not initial vaccinations. So that glass is 37% empty, and it goes all the way down to, in Adams County, for example, 58% empty among the 12 to 15-year-olds, only 42% of whom are vaccinated. Now, the schools are making a lot of efforts to try to beat the drum about getting vaccinations going, but it's honestly, we've still got lots of vulnerable folks from a vaccine perspective, even in the middle and high schools. Next slide, please. So let's shift to masking. And I want to, again, you guys have heard me say this before, but I wanted to put it in one place just so we're kind of all on the same page. Benefits of masking. Why am I beating this drum so loudly and persistently? First of all, masking is not a be-all, end-all. It may sound like I'm a one-note Johnny, but it's not a be-all, end-all. It's part of a package. And that comprehensive set of package includes vaccines when eligible, social distancing when you can maintain it, tough when you've got more kids coming back to school, testing. Our rates are higher than 5%. Maybe we're not doing enough. Good ventilation, staying home when you're sick or you test positive, use of quarantines, and then good cooperation with public health. And I would say so far, our schools have really been bent over backwards to try to be cooperative with us. I didn't put the use of quarantines in italics or bold, but I want to remind all of us that last spring, the use of quarantines is what drove everybody crazy. You got a case in a classroom and you had a bunch of people around that case would have to go home, and then they came back, and then you had another case in the classroom and a bunch of other people had to go home. And every superintendent I talked to said, this is what killed us. And when I talked to pediatricians about, what do you think is going on with the mental health issue? All the metrics look like they're going in the wrong direction. It was isolation and uncertainty, and quarantines were a big part of it. And so a major part of our focus this year has been to say quarantines are an incredibly valuable tool from a communicable disease control point of view, but can we please try to use them much more judiciously than last year? And that's, again, been a big part of the trade-off: more masks, less quarantine, fewer masks, more quarantine. You've heard me say these numbers before. Masks are approximately 50 to 70% effective in reducing transmission in a variety of settings based on both source control from unwittingly infected persons who could transmit to others, as well as wearer protection, the acquisition of infection. They're not perfect. N95s are better than surgicals, which are better than cloth, but all provide roughly approximately a baseline of around 50%. And like vaccination, although we don't have a concept of herd immunity, the more folks in a setting that are wearing masks, the more incrementally valuable that tool is going to be in a given situation. The observations we heard loudly from our schools and many folks who sent us photos and whatnot is that compliance with mask wearing is variable and often, if not usually, low when it's non-mandatory. And the benefits of mask wearing, again, you've heard me say this, turn into individual health benefits, particularly in the unvaccinated or those with underlying illnesses. the health of others, particularly if I've got a family member who's unvaccinated or has an underlying illness. Community health, because when one sees those higher rates in those lower age groups, that's more fuel for the community transmission fire. But then most importantly is the avoidance of school disruption due to the outbreaks and isolation of individual cases. Again, because of the educational, the social, emotional development, and the mental health impacts. Next slide, please, Lisa. And we went over this last time, but I just want to remind you again that we've had a number of expert groups give us advice. This was the American Academy of Pediatrics back in July, recommending that all students older than 2, and by the way, that term is a little confusing. Older than 2 means older than your 2nd birthday. There's been some question, does that mean 3-year-olds? And according to AAP, they're consistent with CDC. It's older than your 2nd birthday. Next slide, please. A week after that, the MMWR, prompted by the Massachusetts outbreak, came out with this recommendation, which I've shared with you: universal masking for all staff and students in all schools, regardless of transmission status situation and regardless of vaccination status, with universal masking in public settings, regardless of vaccination status in high transmission areas. And there's that color code that CDC portrayed at the time, which has shifted very dramatically to the orange and red part of the spectrum as rates have gone up across the country. And as you can see from the map I showed you earlier. Next slide, please. We heard from the Colorado chapter who echoed what the national chapter did. And I shared this with you all. The letter they sent us on August 10th, where they sent it to the governor and they sent it to the head of the state health department, and they sent it to all local public health officials, including me, saying, somebody's got to step up. Okay, the governor doesn't want to do a statewide. The state health department doesn't want to do a public health orders. The schools are saying, it's really hard for us to act without the public health department acting. Please, somebody step up and act. And this was a major impetus, if you will, for the meeting that we had a couple of weeks ago, and my request to you that you consider the public health order that we ultimately came up with. Next slide, please. I just want to remind the board, if you didn't see it this afternoon, Renee sent it out kind of late. The AAP reached out again today. We had several of their chapter members write me and you specifically, pointing out the outbreaks that are now beginning to happen, and very, very strongly requesting that we consider masking at all levels as a requirement in all of our schools. This came out after our board meeting. This is for a statement from Children's Hospital on mask policies. And, you know, I'm looking to the pediatricians, and frankly, I'm looking to children's hospitals as our experts. So I think I'm an expert, but I'm not an expert like these guys are in children's health. And, you know, when these folks speak about this, I think really all of us have got to listen. And again, their big point is universal masking is our best package to enhancing education and enhancing mental health for our kids. Next slide, please. Next slide, please, Lisa. And this came out, actually, I think it was maybe back to that one, Lisa. Can you go back one? There we go. This is a periodically updated, back again, Lisa. Nope. I want to get to the Children's Hospital mask fact sheet. Next one. Okay. This was their updated mask fact sheet. And I blew this up. Again, it's hard to read, although maybe you had a chance to read it when I sent it to you this weekend. It's addressing among about 25 different questions on their FAQs about whether masks can cause mental health problems. Because there has been a concern among some of our parents that masks make my kid anxious. This is what's really making mental health so bad. This is absolutely not the opinion of the behavioral health experts at Children's Hospital, who I will remind you, because many of our letter writers remind me, proclaimed an emergency in mental health among children back in April, that really there's no science behind the concern about masking impacting mental health, that the mental health challenges the kids are facing are multiple, but they're due to a variety of things, including disruptions in routine, and family life and schooling, resulting in isolation, stress, and anxiety. Kids are stressed. That's really clear. I've got 5 grandkids in Denver, and they're stressed. And being back in school and having them connect with other kids and having whatever we can do to help that happen, whether it's vaccines or masks, is the way to really, I think, and at least the experts at Children's Hospital tell me, the way to try to deal with the mental health issues. Next slide, please. Now, I showed you all this before, but I just wanted to say again, there is an enormous amount of both literature, some of it's published and peer-reviewed, some of it's gray literature, some of it's opinion pieces about masks. And I don't think any of us, certainly I, cannot keep up with all the mask data, opinion, gray literature, et cetera, et cetera. I really have to rely upon expert groups, whether it's the American Academy of Pediatrics or in this case, the CDC, this being their science brief periodically updated last version in early May, about the benefit of wearing masks. And they are very clear. We do not have, and will almost certainly never have, a randomized, double-blinded, placebo-controlled trial like we do with vaccines. Forget it. You can't do that sort of trial design. What you can do are observational and epidemiologic studies. And these observational and epidemiologic studies that they cite in this, I think this is about a 15-page document, show based on certain outbreaks in certain situations pretty consistently mask benefits, or a consistent masking reducing transmission by about 70%, which is why they've continued to maintain that the 2 benefits, the wearer control and the source control, in and of themselves end up being a major contributor to prevention. So this will be updated periodically. Not every published article in the world is in here. I think the ones that have carefully met their standards are, and I continue to think this is one of the most useful places for us public health types to try to get our collated information. Next slide, please. And I showed you all this before, but I just want to point out again, this was a very in-depth study done in North Carolina by the Duke Department of Pediatrics, where they studied over 40,000 people requiring quarantine and determined, number one, the secondary attack rate in schools last spring, rates were high, not much vaccination, was less than 1%. And the proper masking in those schools, and it was mandated, was the most effective mitigation transmission. When there was lots of COVID, that was true in the spring, that's true now. And when vaccination is unavailable or there is insufficient uptake. This is their science, not mine. The piece in the New York Times was simply their way of trying to describe it to a broader group in the public. Next slide, please. But we all like local data, and I want to refer again to the local data that we collected in the metro area, and we did more in the springtime, but this was the one I had most easily available, that looked at the question, in a setting where you have lots of mitigation, including high levels of mask wearing, what proportion of students and teachers who get exposed and are quarantined end up developing infection? And the chat is blocking my ability to read. Here we go. Okay, so we had lots of quarantine students, over 40,000 in the first semester of the year. The number who tested positive, 0.4%. Lots of quarantined staff, 7,600. The proportion who tested positive, 1.8%. Higher. The observation of the schools was that actually a fairly sizable fraction of that were faculty exposures in faculty lounges. And we did, in fact, learn that adults, when they're kind of relaxing, may let their guard down. That's appeared to be what's happening in school. But I would suggest to you that what we saw with actually much bigger ends than the group in Duke did was from a transmission perspective, or at least a documentation of infection perspective, almost as low or as low as what was seen there. Next slide, please, Lisa. I haven't shown you this until this weekend. I think this is really interesting. CDPHG is looking at comparisons in case rates between school districts with and without masks. They've currently taken a deep dive because schools started pretty early in Georgia and Indiana. This is the data from Georgia, and it was complete as of the middle of August, so it's a little bit out of date. But I think what you can see, the orange line are the schools not requiring masks. The blue lines are the schools that do require masks. Those lines are diverging more week by week. The current estimate is about a 30% reduction in cases in the mask requiring versus the non-mask requiring districts. Now, this is in fact, of course, the setting that's most relevant to us, not so much what happens at the individual level, but what happens when something is done as a policy or a mandate in a larger setting. Next slide, please. And this is the Indiana data, same setup. Orange is not requiring, blue is requiring. And here you can see maybe even more clearly the divergence over time. As of August 20th, that divergence is about 38% difference in the orange line versus the blue line. Now, Colorado just started doing this data 2 weeks ago. We are also seeing the same kind of divergence, but I'm not showing it to you because there are very, very few schools associated with it. I will make note because many of you have asked, how are we going to follow mask wearing anyway? And I think these sort of comparative data, I actually hope we don't have much opportunity to do comparative data in Colorado because I hope masks begin to be really quite widely used. But I think this provides one of our best clues as to what's going on as a result of these kind of mandates. Next slide, please. So I want to now turn to the third agenda item and talk to the board a little bit about what I think.
Excuse me, before we move on, that was an awful lot of information.
Sure.
I would just ask if anybody is asking for additional information or clarification to please send your request directly to Dr. Douglas to get that information. But in the meantime, are there any questions about the very comprehensive picture of what we know about what's happening in Colorado and what the prevention strategies might be? Dr. Fielding.
I had asked for the number of children who were hospitalized in the Tri-County area, the numbers, not the percentages. Also, for the number of schools that have closed and the number of children that have died. I have not seen that data.
So thank you, Dr. Fielding. I do have that data available for you. Since the beginning of the pandemic, we've had 158 kids in the 0 to 11 group and 149 in the 12 to 17 group hospitalized. In the most recent month, we've had 15 in the 0 to 11 and 6 in the 12 to 17 group hospitalized. Over the entirety of the pandemic, there have been 6 pediatric deaths. These are in people less than the age of 18. There's been 1 in the third quarter. Those are in our 3 county jurisdictions. In terms of schools closing, we've had the outbreaks that I mentioned. At this point, we're only aware of, there are no schools that have entirely closed. We have had some classes and some grade levels closed. I'll make note of the fact that the closures that have happened have thus far been entirely at the school's preference or choice. The issue, and there have been 5 situations that we're aware of where schools have moved classes to remote, although there are others pending. What appears to be going on is that our guidance, like the state's guidance, is that when you have an outbreak in a classroom, then you need to do more rigid quarantine. You need to do quarantine based on proximity of students. We've given a lot of latitude about usage of quarantine. And what the schools seem to be finding is the complication of doing the contact investigation and the complication of setting up parallel in-person and remote learning has been challenging enough that they have chosen to make that decision on their own. I think you're probably aware that there were a number of grades in the STEM school, for example, that made that determination as an example in Douglas County, and that was part of the rationale for that. Dr. Albanese, I think you're part of the panel and you know this data better than I do. Do you want to add anything to Dr. Fielding's question?
No, I think you provided the numbers, and I think you summarized thus far what our anecdotal experience has been working with the schools who not only have challenges with what happens in a particular classroom or school activity to help control spread, but also that, cases are just popping up all over the schools because they're either, coming in from the community all over the school, which then complicates disease control measures around the classrooms. But a lot of those decisions have been made independently by the schools themselves in terms of going to remote.
Thank you. Dr. Faywell.
Thank you. John, on slide 6, the Provincetown outbreak, the CDC used that as their jumping off point, shall we say, to recommend mass use. I'm not sure, if you talk to the people there, and I have a lot of contacts with that type of group, while they tested positive, they weren't hospitalized. There probably were 1 or 2, but I mean, no big numbers. And there have been, to date, and through the contacts I have there, no deaths. Yes, people with vaccination can be carriers, and we know that, but to use that as the jumping off point for CDC to recommend masks universally in any large gathering, it would be probably better if they combined the results there with, say, Sturgis, South Dakota, where they have the massive motorcycle rally, or even better, Saturday night's Bronco game with 76,000 people jammed in elbow to elbow. And if the results seem the same, then maybe they'd have a better basis for their recommendation.
Yeah, good questions, Tom. Let me say, first of all, I did show you the Barnstable data. That was certainly a part of the CDC's concern, as you put it, that unvaccinated people could be mildly infected or even asymptomatically infected and be maybe not carriers. Carrier sort of implies long-term, but certainly currently infected and asymptomatic and transmitted. And that was part of it, but it was in the context when this stuff came to light at the end of July of realizing Delta was shooting up fairly dramatically. We'd already begun to see what was going on in Arkansas and Missouri. So it was the context in addition to that. Now, Sturgis is an interesting question. South Dakota's rates have gone up, I don't know, about 40 or 45% since Sturgis. I haven't seen any, Barnstable-like detailed analyses, but listening to some of the docs in that state that have been interviewed about it, it does appear that Sturgis did, like it did last year, really serve as a nidus of pretty high rates of transmission. I can't speak at this point to hospitalizations. I do think in Sturgis, probably, just like at a Broncos game, probably the great outdoors gives you a lot of forgiveness. And I think that what I've heard from talking to Massachusetts is that there was a lot of gathering. A lot of it was outdoors, like Sturgis and like a Broncos game, but a lot of it was indoors. Provincetown has got a rich culture of tourist attractions and bars and whatnot, as does Sturgis. And I think that's probably what's going on, at least in large part there. You are absolutely correct. The very few people in in Provincetown got sick. I think it was out of the total, maybe 3 hospitalizations. And so it's, in that case, in a highly vaccinated group, not so much that, highly vaccinated people are going to give it to other highly vaccinated people who aren't going to get sick. It's rather the fact that highly vaccinated people can carry it. And if they're around other vaccinated people, with even in Massachusetts now, the rates of complete vaccination are, maybe 75%. We've still got a pretty big fraction of the population where there are pockets of unvaccinated people. And that's, of course, what's driving some of the settings that are experiencing extreme hospitalization issues right now. So your points are well made. I think, honestly, tonight wasn't so much to talk about the recommendations for masks in all public indoor spaces setting. I'm not here to talk about that as another mandate. I do think the logic makes sense based on, again, the fact that we've got a substantial number of folks that are still unvaccinated.
Thank you.
Okay.
Kevin, did you have a question?
Yeah, I do. Thank you. Yeah, so Dr. Douglas, you mentioned the per 100,000 of hospitalizations, and you're pointing to the individual numbers on your slides that are showing. And when I look at that and I cross-reference the percent of hospitalizations and the number that's on the dial, it's not even halfway to the blue section of the lowest dial number on blue. So why are you having a more stringent mask mandate for that age group over and above the dial when at the worst part of our pandemic, when we have 75 or 70 years and older, 98% of those folks have been vaccinated. The average death in Douglas County, average age is 81. And in addition to that, we've only had one death below the age of 18 since the beginning of the pandemic in all of Douglas County. So I'm confused on why we're going backwards on what's already been decided by the dial by moving away from it. And now you're showing a lower number and at a higher focus level when we're not even halfway to the lowest level on the dial. I'm confused by that. Can you help explain?
Sure, I'd be happy to. First of all, you're right. We did set 2 hospitalizations per 100,000 as a threshold for the capacity restriction public health orders in the springtime. As a reminder, those weren't about schools. Those were about reducing restaurant, gym, bar, et cetera, kind of capacity. And we felt that metrics of severity rather than metrics of case rate was an appropriate thing to do in community settings, especially in settings where there were economic repercussions to capacity changes. This is a different matter now. We aren't disinterested in pediatric hospitalizations, nor are we disinterested in the transmission from kids to unvaccinated adults or vaccinated but immunocompromised or vaccinated but potentially with waning immunity adults. We are interested in both of those, but neither of those in and of themselves is overwhelming. What is overwhelming is intra-school transmission and the interruption of in-person learning. So this is largely, this whole conversation is a school-focused conversation. It's to enhance our ability to keep kids in school and not have the interruptions that plagued us in the springtime.
Well, with all due respect, throughout this last year and a half, I've asked for the data, the support that restaurants were spreading more than any other industry. And we got to a spot with Melissa and I, and it turns out that information is not available. And it's not out there. It's all pushed down from national narratives. I'm afraid that this now is becoming the mask mandate because look, over the summer we had 100% mask compliance in July, and we had 99 the month before that. With cross-section over that, COVID was at its highest for positivities. So I mean, this exercise again to keep microscoping down into the nth degree and looking at, when you look at that number, that's one person per 100,000 in that lower age group, one person in the hospital in all our county, and we're masking. Strange to me, but thank you for answering my question.
Yeah, Kevin, I appreciate it. You have been a diligent reviewer of our data, and you've always asked us good. Hospitalizations are important, but it's trying to keep kids in school. We don't have the capacity to do elegant superintendents. That's why in the world of restaurants and very heavily on the observations that were, and that's why the kind of thing the Duke Group other places is so important. So I use, Georgia data that I can put my hands on.
We have 3 counties that we compare.
we've got a head start by looking at school earlier, and we've got differences between.
Okay, thank you. Jan, did you?
Yeah, I just wanted to, we're dealing with a group that's under 12 for one comment. The other, and now again, like we have with adults and for kids in hospitalization and death. I would like Dr. Douglas if he could speak to the fact sick enough to get into the hospital. What are being compared is long affecting children, and I think people need to know that to go in the hospital enough to go into the hospital. Its main premises is and so I'd like to hear him explain if there what is happening to some of these kids.
So the long hauler syndrome, Jan, is a major issue in COVID. It took us 3 or 4 months into the pandemic to recognize it. Pretty unclear as to what's causing it. It's a pretty amorphous syndrome with shortness of breath, cardiac palpitations, brain fog, loss of hearing. The international team trying to put together how to study long COVID has come up with 201 symptoms that may be related to that. Some of that may be background noise. We don't know. A lot of it appears to be real. In adults, it looks like best estimates are that symptomatic people may have a 20 to 25% risk of symptoms persisting for at least 6 weeks, and the majority of those persisting at least 6 months. Those studies included very few children. And so I don't think we know yet, other than to say there are children with long COVID. Bernadette, I don't know whether as our pediatrician, you can add anything to that. When you and I discussed this a week ago, I don't believe there are any quantitative estimates for kids at this point.
Not just that yet, John, in published studies. There's not data out there yet.
Great, Jan, I think it's a great question, and if there is more information, we'll be sure to get it to you.
Thank you.
I'm not seeing any more questions, so I'm going to move to the next item on the agenda, which was the reconsideration of the current opt-out policy. Dr. Douglas, did you have some comments?
Yeah, I do. And Lisa, if you don't mind going back to the slides, I sort of tried to pull it together. So while Lisa's pulling that back up, I'll do a recap on. I know that you all know Douglas County did choose to opt out. I think it was the day after the order was issued. Last week, Adams County chose to opt out as well. Pretty contentious situation. One of the major messages that came to us from Adams County is that we support masking. We support mask mandates. What we don't support are boards of local officials being asked to tell other boards of local officials, i.e. school boards, what to do. And if you're going to ask us as non-public health experts in Adams County who have paid to have a health department and would rather have the health department making decisions that involve public health expertise, if you're going to turn that back over to us, at least 2 of the 3 folks who voted no, I don't know how, or voted to opt out, said, we're voting to opt out, not because we don't believe in the value of masks, not because we don't believe in the value of mandates. It's that we don't think this was an appropriate decision for us to need to make. We initiated our opt-out policy by way of memory, and I think, Kevin, you're new, but you were following this pretty closely, last November of 2020. The policy gives commissioners, and only commissioners, I would point out, the ability to opt out to the application and enforcement of countywide orders. It is actually not available to individuals, businesses, schools, or school boards under the policy. And I say that because there's been a lot of confusion over the last week about, I'd like for my school to opt out. My principal tells me that as a family, I can opt out. And certainly, this sort of provision is going to have very, very variable reaction. We completely know that. But I just want to be clear that legally speaking, the opt-out policy the board adopted was for county commissioners. The board enacted the policy at a time first of all, there was a lot of controversy, as I think everybody recalls, with Douglas County. Douglas County felt that they were under the jurisdiction of a board, 2/3 of which didn't come from the county, making important decisions that were impacting the economy. It was at a point in time that most public health orders were being issued by the governor and CDPHE. And what's changed since then is that the governor is, at least for the time being, largely gotten out of the issue of exerting executive leadership in the public health order space, and has stated over and over again that public health is a local concern. Public health needs to be carried out at the local level. We're the only health department that has such an opt-out policy. And while as we try to think about how we carry out our statutory duties to control the spread of disease and respond to public health emergencies, it's becoming increasingly clear to our staff, and let me personalize this to me as the person responsible for executing these things, that the current opt-out approach has created concern and confusion among many local elected officials and residents. It was done for well-intentioned circumstances, but I firmly believe that after, what is it, the end of August, we're 10 months into this, that it severely limited the ability of Tri-County to carry out our statutorily required public health duties. Next slide, please, Lisa. Now, these are some examples of things. I mean, I think most of you know it. Kevin, you haven't gotten the orientation, but you've been following public health for a while, so you're probably aware of these. So these are the things that we're supposed to be doing: investigating, controlling communicable diseases, establishing and maintaining and enforcing isolation and quarantine, closing schools and public places and prohibiting gatherings of people when necessary, in the event of a public health emergency, issuing orders for the proper exercise of powers and duties, and that the board likewise may issue orders that they deem necessary for the proper exercise of power and duties. Now, statutory language is pretty clear. The responsibilities and duties of these above, and this is by no means an exhaustive list, but it's ones that seem particularly relevant to the COVID epidemic, are exclusive to public health. And public health officials are tasked with these responsibilities, and those that are tasked with them have to meet certain requirements. So a department that's doing these things has got to have a physician director. And if the director is not a physician, they've got to have a master's degree, and they've got to have a public health medical official assisting them with this. My feeling is that as I've watched the vacuum left by the governor saying this is a local matter, I'm not interested in doing local control. The legislature has created a set of statutes that empower local health departments and give them the duty of carrying out certain responses. And as I've watched what's happened in the last 10 months, having been, as I worked with you guys, a proponent of trying this, I think this has not worked effectively. And I think it's become glaringly apparent as we have a resurgent epidemic with Delta, and we have really, I would say, in the absence of the state health department taking action, a vacuum of public health effort to address these issues. Next slide, please. So as I shared with you in the draft slides, given these concerns, my recommendation to the board tonight is that the opt-out policy be rescinded. And I would recommend a motion something like the following: that the policy regarding these issuances of countywide public health orders, and the Board of Health policy allowing county commissioners to opt out, be rescinded. And I would ask the board to entertain this proposal this evening.
Thank you. We'll entertain whether there's a motion and a second, and then we'll have discussion. Is there a board member that would like to move as per Dr. Douglas's suggestion? Julie?
Hi, I'd like to make that motion, please. I move to rescind the policy regarding issuance of countywide public health orders the Board of Health policy allowing county commissioners to opt out of the application and enforcement of countywide public health orders issued adopted by the board on November 6, 2020.
Thank you. Is there a second?
Kaya, this is Jan. I second the motion in order to move to discussion.
Great, thank you. So now we'll have discussion, and as I said before, we're going to use the same rules we use for our public comment period, try to get a diversity of points of view, both for and against, and limit the comments to 3 minutes. Lisa, you're our timekeeper. If I begin the roll call, are you all set to do the timing?
Yep, whenever you're ready. Do you want me to unshare while we do that?
No.
Okay.
Dr. Fielding, did you want to begin?
Actually, I want to bring a criminal matter to this board's attention. And I would have done this earlier, but we have a rule now with the way we interpret the sunshine laws in open meeting. And I want to read into the minutes here, CRS 188306, attempt to influence a public servant. Any person who attempts to influence any public servant by means of deceit, by threat of violence, or economic reprisal. Basically, it's a class 4 felony. And I have information directly about one case, and there may be other cases that I suspect. And this is concerning board members who have been basically compromised because they have had complaints filed against them. And this is against their professional licenses for the work that they have done on this committee. And what that means is, this is basically a compromised meeting. It's tainted by an atmosphere of coercion. And at this point, I would move that we basically cancel this meeting. And I know our attorneys are aware of at least one case until we can resolve the status of those board members, because I don't think at that point you can have a fair vote.
Well, I'll just point out that we do have a motion and a second already on the floor. According to Robert's Rules of Order, we cannot have a second motion until we resolve the first one. So I would like to move forward with that vote, and then pending a conversation with our lawyer, we will entertain your concern about the need for to address the challenges to the board members. So we have a motion on the floor to rescind the countywide public health orders. We have a second. So Dr. Fielding, did you have a comment about this order, or are you abstaining from commenting at this point?
If I actually do have a comment about that.
Okay.
I think it is the opt-out is a necessary safety valve, and we've seen it, because not only has Douglas on this contentious issue opted out, this is a political issue, and Adams County opted out. And if I heard this correctly, it's the silliest excuse I've ever heard of. We opted out because we don't like opt-outs. This makes no sense, and we have gone into the twilight zone.
Okay, thank you. Kevin, did you have a comment about this motion that's on the floor?
Yes, I do. I will be a no vote on opting, having the folks opt out. I think that the flexibility that as a town council member, and Dr. Douglas mentioned that specifically that it created confusion with the political officials. I tend to disagree with that. I think that that empowered our community to be able to support and get behind something that they could research their own data and be able to follow through with their own knowledge and base, and either support the commissioner's recommendation to opt out or to not. And more to that point, if people need to wear masks for whatever reason, fully supported. I've seen people around town, and and they're wearing masks. Even some of the folks that have been vaccinated are wearing masks, and that's their own personal choice. And I think we're at a spot where folks need to start making their own personal choices, and they need to, if they're compromised, they need to protect themselves and not have the least effective folks, which are the children, carry the burden on behalf of adults. So those are my comments, and I will be a no vote. Thank you.
Thank you. Dr. Baywell, did you have comments about this order, motion?
Yes. The opt-out approach, whether stated in so many words or not, is part of everyday life. Let's say exceptions. Exceptions can be put in for opt-out. And exceptions to the rule abound. I mean, childhood vaccinations are required for school attendance, with exceptions. Last year, the governor issued statewide mandate for masks and stay-at-home orders, with exceptions. That being said, however, our present opt-out policy appears to be overly facile. It allows outside influences to overrule science and medicine for certain agendas. My position would be to have an opt-out policy that's amended. I'm not in favor of throwing the baby out with the bathwater. I realize our actions and policies reach far beyond just the health aspects that we can see. That being said, on both of these issues, we're damned if we don't and damned if we do. And it's a uncomfortable position to be in. Thank you.
Thank you. Jan, did you have comments?
I did. When this first was discussed, it was a very crazy time. We were just getting into the whole pandemic and trying to figure out what was what. But the basic premise of it was, I thought, that we would be discussing and we would have talk with the commissioners. We would have understandings of each other's views. Where it totally became apparent to me that this was not functioning the way it should and was meant to function. When counties make public statements before we even order an issue on the media, etc., then it's not working, because we have heard people opt out of policies that weren't even made yet. So I'm not in favor of keeping that in. Thank you.
Thank you. I'll just mention that I am concerned, given the trends in COVID, that what we've created is a policy that creates a patchwork of responses that's very driven by political decisions. And so I am for the rescinding of the opt-out policy. Julie Schills, did you want to share your comments?
Yes, and I want to thank Dr. Douglas for sharing the information and also, reminding us all of the responsibilities of public health. I was not a part of the board when the decision to have the option of the opt-out available. And I would agree that it's really hampering the ability for the public health department to follow through on the responsibilities that they are mandated to do.
Thank you. Rosanna, did you have some comments?
Yes, I want to thank Dr. Bernadette Albanese and Dr. Douglas for his very thorough presentation. I did not vote for the opt-out back in November. It seems like a very long time ago, and I'm definitely in favor of this motion.
Thank you. Julie Mullica?
Yes, thank you. So I support this motion. I feel like the opt-out policy has caused significant confusion throughout our communities. I feel like it was detrimental to the governance and public health authority of the Tri-County Health Department. And so I really appreciate Dr. Douglas bringing this forward, and along with his concerns, I feel like this is is a much needed step. Thank you.
Thank you. Renee, can you help us if we do a roll call vote at this point?
Yes, I can.
Okay. Did you want to call everybody's name and then see how they would vote? Just say yes or no when Renee calls your name.
Absolutely. So representing Douglas County on the Board of Health, Kevin Bracken. Oh. I'm sorry, did you say no, sir?
No, yes, no.
Thank you. No. All right. Dr. Linda Fielding.
No.
Kim Muramoto is absent from the meeting. Representing at Arapahoe County on the Board of Health, Dr. Kaya Gallagher.
Yes.
Dr. Thomas Faywell.
No.
Jan Brainerd.
Yes.
Representing Adams County on the Board of Health, Julie Mollica.
Yes.
Rosanna Reyes
Yes.
and Julie Schills.
Yes.
We established at our last Board of Health meeting that our bylaws say that motions pass by majority vote. And by my count, that was a 5-3 vote in favor of the motion. So it appears that the motion is approved. We had a second item on the agenda that I'd just like to make sure we get through. And Dr. Fielding, I have not forgotten your concerns. Dr. Douglas, did you want to share some information on revisiting the school mask mandate?
Yeah, I'm happy to do that, although I don't know whether we need any clarification about the order. I'm happy to proceed if you think that's appropriate versus Dr. Fielding's question.
Randy, did you want to comment on Dr. Fielding's concerns?
Dr. Fielding's concerns are something that I think should be discussed in executive session because she's raising some legal questions, including a statute concerning attempts to influence a public servant.
Okay. If it's okay with you, Dr. Fielding, we'll proceed with our meeting today, and then we'll try to convene an executive session as soon as possible. Is it possible for us to extend tonight's meeting? Could you raise your hand if you are available for an executive session after tonight's meeting? Okay, so 1, 2, 3, 4, 5. 6. Rosanna, are you not available? Julie Mullica, you're not available?
I am not. Sorry.
Okay, we only have 6 people. It seems like this is a really important topic. Can we try to convene an executive session tomorrow or Wednesday? Yes, Kevin, did you have a suggestion?
Yeah, no, I have a question concerning the vote. How many eligible voting members? I believe was it 10 and 1 was absent? Is that right?
No, we have 8 board members present. 1 is absent. Ordinarily, we have 9, and we had 5 in favor and 3 against.
So all eligible board members voted, correct?
Yes, all eligible board members voted.
Thank you. I just wanted to clarify that. Thank you.
Okay. Yes, Dr. Fielding.
Well, I would like to make another motion then. And that motion is that this meeting is improperly called as an emergency. It is obvious from what we are discussing that there was no reason to have this on such short notice. In fact, one of our own board members could not make this. I do not see the emergency. I do not see what has happened in COVID in the past 2 weeks. And I do not see what the problems with the opt-outs are. So I think this has been an improperly called meeting with very little notice time and very little time for public comment.
I'm sorry, are you making a motion?
Yes, and my motion would be that we terminate the meeting as of this time, and whatever we have discussed is void at this point until we reconvene in our normal monthly meeting.
Is there a second for that motion?
I'll second that.
Okay, we'll just do a roll call vote and see if we have a majority of people who agree. Renee, could
I ask a
Yes.
question?
Yes.
It was not my impression that this was an emergency meeting, that this was strictly a board meeting, a special board meeting. Did it ever propose to us to be an emergency meeting?
I don't remember using that word, but I think Dr. Fielding wants to void the meeting anyway. Is that not correct, Dr. Fielding?
Actually, because of the fact that it was called on short notice and when it was discussed with me, we had to get this done immediately. That to me is the definition of an emergency or an irregular meeting. And what we did today could have been just as well discussed in our normal monthly meeting. So I do not think this was an appropriate meeting, and I do not think it is a valid meeting.
Okay, it looks like we have some discussion about that. Dr. Faywell, did you want to comment?
Bylaws of our board allow for meetings to be called within 72 hours.
Okay, so we have the authority to do that. Kevin, did you have a question or comment?
Yeah, I just, the concern, I heard Dr. Fielding's comments, but I don't know what the substance is. So that's why I seconded the motion, because, I mean, to have allegations out there seems pretty serious for any board. So that was my second. I'd like to, I'd like to hear, what the situation is and be able to weigh in on and have the group weigh in on impropriety. So,
well, unfortunately, as Randy, our lawyer, pointed out, there's some privacy issues involved, and we would have to discuss that with you in executive session. And it appears as if we don't have enough board members to be able to do that. I'm prepared to schedule an executive session to discuss this, but I unfortunately can't accommodate it tonight. Dr. Douglas, did you have a comment?
I just wanted to clarify that to the other board members, I talked with Dr. Gallagher about organizing this special meeting. I mean, technically it's called a special meeting, not an emergency meeting, because I felt that the nature of the situation with the rising rates, 2 counties opting out, a third on the considering that, deserved immediate attention. And I felt like we immediately needed to address the opt-out issue. And depending on how that turns out, immediately discuss what ought to come next about a mask mandate. So I just want to be clear to the board that I felt very strongly about the timing of the meeting.
Okay. I think there's a motion on the floor and a second. So I'll call for the vote. Renee, could you ask each person which way they want to vote, please?
Could you just read the motion again, someone, please?
Dr. Fielding, could you repeat your motion?
My motion was that this was an improper meeting with improperly short notice, and that the matters could have as easily been discussed at our regular board meeting. This did not mandate a special meeting, and so I believe that this matter should be invalid, and we should table it now and finish the discussion at our regular board meeting.
Okay, thank you for that clarification. So I'm going to call for the vote. Renee, could you call each member, please?
Absolutely. Please state yes or no after your name is called. For Douglas County, Kevin Bracken. Dr. Linda Fielding.
Okay, I am obviously for my own motion.
Of course you are, but we still have to ask. Kim Muramoto is absent. For Arapahoe County, Dr. Kaya Gallagher.
No.
Dr. Thomas Faywell.
No.
Jan Brainerd.
No.
For Adams County, Julie Schills.
No.
Rosanna Reyes.
No.
Julie Mollica.
No.
Okay, thank you. It seems as if we had 6 people against and 2 people for, so the motion did not pass. I'd like to move to the next item on the agenda if possible. And Dr. Fielding, if for some reason in the course of our conversation, we need to revisit these votes, we will. But for right now, I'd just like to move forward with the discussion and the motion. Dr. Douglas.
Yeah, thank you, Kaya. Next slide, please, Lisa. So, sorry, the one after that. Yeah, I wanted to raise the issue, as I said in the email to you all, in our public agenda of school mask mandates. So, as I just said, our current order covers folks 2 to 11. It's now been opted out by 2 of the 3 counties. The third one's pending. As we've talked about, we've got rising rates in both those over 12 as well as 11 and under, only 50% to 60% vaccination rates in our middle and high school students, increasing outbreaks in all levels of schools. I do want to make note that our childcare facilities have asked questions about the difficulty in masking 2-year-olds, and we'll come back to that. I also want to make note that there is a universal mask order in place for most metro counties, including Jefferson, Boulder, and Denver. So it is sort of hardly, if you will, unique that this be considered. I want to make clear to the board that as per Dr. Faywell's motion last time, we are following a number of variables. We just actually posted like 3 minutes before the meeting a dashboard where these can be followed. These variables that are relevant to how the need for and the effectiveness of a mask mandate include case rates by county and census tract, county case and hospitalization rates among kids, hospital capacity, excuse me, school case and outbreak numbers and trends, vaccination rates among 12 to 18 and greater than 18-year-olds, and then updated expert advice. That's not on the dashboard, but we will be attentive to what CDC, CDPHE, AAP recommend about really preventive measures in schools in general, but particularly masking. Next slide, please. I wanted to make a recommendation tonight that given these concerns, that our current public health order requiring masking, again, already opted out of in 2 counties, be rescinded, and that it be replaced with a public health order that would require masking for everybody 2 and above in schools and childcare centers in the 3 counties of our district. I'm recommending some motion language to the board, that being to authorize and direct the executive director to rescind the public health order we passed on August 18th. And in response to the COVID-19 pandemic and to support and limit interruptions to in-person learning, replace that order by issuing a public health order requiring face coverings for all individuals 2 and older in all indoor school and childcare settings in our 3 counties. I'm recommending that this be done as soon as feasible, beginning on Wednesday the 1st, staying in effect until December 31st, unless it's amended, extended, or rescinded. And as already pointed out, the health data and community conditions will be continued to monitor daily while the order is in place.
Thank you. I'd be willing to sponsor that motion. So I move to authorize and direct the Executive Director of Tri-County Health Department to rescind the public health order requiring face masks in schools and childcare facilities that was issued on August 18th, 2021. And in response to the COVID-19 pandemic, and to support and limit interruptions to critical in-person learning for all students, replace this existing order by issuing a public health order requiring the use of face coverings for all individuals aged 2 years and older in all indoor school and childcare settings located within Adams, Arapahoe, and Douglas counties. The order shall become effective at 12:01 a.m. on Wednesday, September 1st, 2021, and shall stay in effect until December 31st, 2021, unless amended, extended, or rescinded. Health data and community conditions shall be monitored daily while this order is in effect. Is there a second?
This is Julie. I second.
Great. Do we have, we're going to go through the list of everybody to ask for comments. Dr. Fielding, did you want to make a comment about this motion?
Okay. Do I get a chance to talk? Okay.
Yes, it's your turn.
Okay. So what I would say here is this is just another batch of bureaucratic overreach. The schools are responding appropriately. They are responsible to the electorate, and there will be elections in November. I think this is unnecessary, and we have just put ourselves against the will of the people who have given us overwhelming information that this is not what they want.
Thank you. Kevin.
Yeah, I have some strong comments on being against this this motion. You are, and we are collectively masking the wrong demographic. We're masking the least at-risk demographic. We were trying to protect, right? We were trying to protect that 70 plus, and 98% of those people are vaccinated. 98%. And now you're going to have kids wear masks within the school system and then walk out and hang out with their buddies on the weekend, which is likely where they're probably contracting the COVID-19. So, from my perspective, is this board is completely missing the mark on protecting the people that are vulnerable, and they should be masking themselves, and they have to have some personal protection. You are punishing the kids, the ones that can't protect themselves, and I'm standing up for them right now. You are making them wear masks to protect somebody within their home, when that person at home should be wearing that mask, not the children. And the vaccination rate, you run through it, 60 to 69 is 88.51 in all of Douglas County, 50 to 59 is 77.3 vaccinations for all of Douglas County. And we haven't even talked about immunity from people that have had COVID. So again, these decisions that you're making, you're punishing the children. I know you think, if you're on this board and you think that you're making a decision to mask them for some greater service and good, we went through the whole mask concept. And Dr. Douglas admittedly saying in his opening speech on his PowerPoint that the viral load for children is low. There's only one person in all of Douglas County in the hospital right now from COVID-19 that's below 18. I looked at the numbers on the dial. The numbers don't support masking these kids. Protect the vulnerable, protect the elderly, the folks that have died, the 81 years and old elder that died. 218 were 75 plus deaths in all of Douglas County. And you're punishing the wrong demographic. I'm a no vote on this adamantly, and stop presenting the data at the individual and each level, and when it doesn't even reach the bottom of the dial. You're skewing the information, in my opinion, and it's wrong. Thank you.
Thank you for your comments. Dr. Faywell.
Yeah. Masking issue is a complex and difficult one. Threats and intimidation notwithstanding. To those of the public who believe their voices aren't heard, I can assure you they are heard loud and clear on both sides of the issue. Being heard and agreed with, however, are two different things. It was in the 1770s, there was a representative to the British Parliament, Edmund Burke, who said, and I'll paraphrase because Old English isn't our thing, a representative owes not only his hard work, but his judgment. And he betrays you if he sacrifices his judgment to yours, he's the one, obviously, in other words, who's done the research, who's done the work, who's looked at it. Well, back then they didn't have the internet so that everybody could do a little bit of research. However, it's where you're doing your research and where you're getting your information from that can cause problems. That being said, 30 plus years of working in a surgical mask allows some insight into the physical and mental effects, of which, for me, there were none. Unless one's, maybe you point out that being on this board since 2003 is an indicator of some kind of mental issue. Could be. That being said, masks aren't perfect. As Dr. Douglas said, they aren't the be-all and end-all of what we're doing. They're not only or necessarily the best choice in every case. When you looked at one slide, we had 5 factors to make a determination on what to do in the case of this pandemic. Of the 5, the one that might apply to us was community transmission. The information that we've looked at, most of the trends are on the rise, but we went over 7-8 months talking about the rates aren't what we need to focus on, but rather the hospitalizations. And although one of our board members isn't here today, one of the things that she does is to look through the information and the data day by day. And I have that information. And it just doesn't support yet the need to go to universal masking. There is an increase, and we have to watch all the indicators. Thankfully, they're still reasonable, but they could change, and we have to be ready. And that includes having a meeting called on short notice. Not an emergency meeting. That would be when, we have an attack or something, but and as I said, vaccination should be what we're focusing on. That gets us out of the problem. We have to keep looking at keeping children in school. If you talk to teachers, kids don't seem to have as much problem with the masks as the parents who send them to school. One anecdotal was the parent who's vehemently against masks, whose student, after being dropped off, pulls the mask out and puts it on. Teachers who have had to teach remotely can tell you that isn't the way to teach. It's teaching to a blank screen sometimes. And so doing what we can to keep everybody in school, one way or the other, is appropriate. But are we doing the right thing with focusing on one aspect, mask, and not the distancing, vaccination where we can do it, hand washing, which, by the way, is pretty abominable in any men's room that you go into. And from what I hear, it isn't any better in the ladies' room. People quickly forget how to do the easiest things. We will continue to have problems with this virus forever. People have to change their habits. Masks are just one aspect. Thank you.
Thank you. Jan?
Oops. Thank you. This has been a subject that has caused so much angst for all who care to feel passionate about this. For me, this is a positive because it shows we're not apathetic people and have the freedom to voice our opinions. We all wish certainly that this epidemic had never happened. I would like to take a little bit of issue with what was stated about who we're protecting. I would remind people that the protection is for the people who are not yet vaccinated, who can infect each other. Those are the children, especially under 12, and also the children who are under 12 who live with high school seniors or high school juniors or whatever, and are in all three of these schools and are causing this cross part. However, with my professional knowledge, background, and positive intentions, my assessment is this action is the best action that can be taken right now by a health department for time to protect our children and to keep them able to attend school for their best chance of furthering their academic achievement. Thank you.
Great. Thank you. I would just like to share the statement from Colorado's leading healthcare organizations, the American Academy of Pediatrics Colorado Chapter, the Colorado Academy of Family Physicians, the Colorado Child and Adolescent Psychiatric Society, and Immunize Colorado, who in a letter today to the Arapahoe County Commissioners said they unequivocally recommend universal masking to keep students in the classroom where they need to be in order to thrive during the school year. And for me, it's really a focus on keeping the children in the classroom to the extent possible. Thank you. Julie Shills.
I would like to echo that we do have a lot of passionate individuals who have sent us messages. They are messages both for and against masking. So we received a lot of information, and I agree that it is really reflective of having engaged citizens. As I stated in our previous conversations, as I think about this, I'm not considering politics. I'm thinking about children. I'm thinking about the evidence that we have before us in this unprecedented time. And I'm thinking about many of the consistent messaging from parents that they want their children to stay in school. And that all of those, along with the information from our associations related to pediatrics and their recommendations, are driving how I vote tonight.
Thank you. Rosanna?
Hi, yes, a lot has been said, particularly by my colleague, Julie Schultz, fellow nurse. I trust the Colorado Academy of Pediatrics and Family Physicians and the other healthcare professional organizations that Dr. Gallagher spoke of. I support doing what we can to keep children in school. The role of the Board of Health is to prevent infectious disease, prevent death, and also prevent children, as we're focusing on children today, from ending up in the hospital. So I support this.
Thank you. Julie Mullica?
Great, thank you so much. And I guess being last gives me the opportunity to echo a lot of what everybody else said. So pretty much, I, of course, believe in that this is the right thing to do. We are following current public health guidance. We're listening to our professional medical associations. And overall, we have an obligation to protect our community. And frankly, because the only thing I'd like to add is because we're not seeing executive leadership on this issue, I feel like there's an obligation for us to take action in this area. And then I echo the many other positive things that have been said about this motion. So thank you so much.
Great. Well, are we ready to take a vote? It appears as if I'm not seeing any more requests for comments. So Renee, could you do the roll call and ask people what their votes are, please?
Yes, and for fun, I'm going to mix up the order a little bit. Representing Arapahoe County, Dr. Thomas Faywell.
No.
Dr. Kaya Gallagher.
Yes.
Jan Brainerd.
Yes.
Representing Adams County, Rosanna Reyes.
Yes.
Julie Mullica.
Yes.
Julie Shills.
Yes.
And representing Douglas County, Kevin Bracken.
No.
Dr. Linda Fielding.
No.
And Kim Muramoto is absent.
Thank you. It appears again that we have a majority in favor of this motion. The vote by my count was 5 for and 3 against. So the motion passed. Further information about these motions and the subsequent policies that are going to be developed will be posted on the Tri-County Health Department website. And I would like to mention a note that within this motion language, there is an indication that health data and community conditions will be monitored daily. The motion has an expiration date, and the Board of Health will continue to pay attention to this information and revise the policy as needed. Are there any final comments? I'll just remind people again that there is this pending request from Dr. Fielding for an executive session, and we will try to schedule that expeditiously. We just need to get everybody in place. Kevin, did you have some final comments?
I'd like to make a motion.
Okay.
I'd like to make a motion that should the numbers drop in the next week or two, that a review and removal of the mask mandate happen immediately and as fast as possible, based on the data and information that Dr. Douglas presented. And I would like that flexibility to apply to the prior motion.
Okay. Well, thank you. Is there a second?
I second it.
Okay. Is there discussion? Shall we just go through again the conversation? I think, Kevin, you've already made your statement. Dr. Fielding, did you want to say something about this?
Yes, actually I do. We need to have endpoints in these, and we don't always look for our modeling team. Basically, we should pick a point at which, when the numbers drop, and I don't mean, maybe 100% drop. They'll drop from 2 to 1 child, that we ought to reconsider it. We need hard numbers and we need hard data.
Thank you. Dr. Faywell, did you have a comment?
I believe in our motion, in the motion that passed, that we did address the fact that we'd be looking at the data on a daily basis. The motion seems to be redundant. We've already covered that fact, but it's on the floor, so we can vote.
Okay, we're going to go through everybody's first, and then we'll go back to Kevin and Linda. So just hold on. Jan, did you have a comment?
Yeah, there was a
I
lot.
like Kevin.
Excuse me. There was a lot said in that motion, and I think I heard, Kevin, I apologize if I heard it wrong, that you said within a week or two. Could someone just clarify that for me?
So can I restate the motion, if it pleases?
Well, it's already on the floor, I think. I don't know. That's Robert's rules. I don't know. But I was just asking to hear it so that I could respond to it. Was your original 1 week, 2 weeks?
Well, I would prefer the motion to be a weekly review with the option to remove the mask restrictions should the data move in the correct direction. And I'd like to see, moreover, a percentage point, because we were using a dial before, and now we have no real metric to go by other than what Tri-County Health forwards out to us. So I'd like to have a data point around that and have a weekly review.
Jan, did you have?
I addressed that before you change any motions. My response won't be different whether you change that motion around to what he said or what he said previously. My comment is this: I can certainly see what Kevin's talking about, and I would be in agreement to that. In part, I think we already said we would monitor it, but I think monitoring it and looking at it is certainly important. That would be the intent for all of us because we never intended to just say we wanted this mask and to go on forever and that would be the end of it and we're done. We certainly would go by what he's saying. However, I would caution that different schools have started at different times and it takes a little while for these cases to manifest themselves. So I think a week or two, maybe a little bit too short. Plus, I also think that since that had already passed, we want to be able to support our schools, their staff, and the kids in getting their heads around how is this going to work, and let it work for a little bit at least, rather than saying nope. And then what would follow is, logically, if the numbers go up, oh, they got to slap the mask back on. So I'm just urging caution that we think, I agree with it. He's saying that if we can make a case that it's no longer necessary, boy, I'd be the first to tell you I would be in favor of that. But I just want to caution how we go about deciding where it is. If he wants to use data, fine, but also looking at how long and how the schools have been in now. Douglas County has obviously been in longer. They have a pretty good feel, I'm guessing, but the mask order, even for the younger kids, hasn't been in effect that long. So that's the only thing I would say is if we go that route, is if we look at it, but we use it according to some of the endpoints and logical endpoints rather than just 1 or 2 weeks.
Okay, thank you. Dr. Douglas, did you want to make a comment?
Sorry, just what Jan said. Kevin, I get the idea of having metrics. I think it's a good idea. We will be tracking on these things closely. I do want to say again, this is really different than the dial, which was focused on community capacity. This is keeping kids in school. The issue is that there will be a substantial lag. One will need to see community rates fall and no outbreaks, and then have to be comfortable that when you pull back what's at least been temporarily associated with no outbreaks, you're not going to see that rebound. So it's really what Jan said. So thank you, Kaya, for letting me offer that.
Sure, thank you. And I'll just repeat that since I was the champion for this motion, that the intent is to have a daily monitoring of the conditions, and the language does say amend, extend, or rescind. And in the happy event that the situation improves, we do have the ability within the stated motion to revise it. We don't have to wait until December 31st. We really have that ability. So I would just say, Kevin, that I recognize what you are proposing. I would agree with it, but I do think that your motion is redundant with what's already with the language that's already in the motion. That's just my opinion. Julie Schills, did you want to comment?
I would agree that the language in the motion is to look at this data every single day, bring in all the information. We need to allow our public health department to do what they are accountable to do based on statute. And there are endpoints to this recommendation.
Great. Thank you, Rosanna.
I agree. I think Mr. Bracken, perhaps he hasn't been on a health board previously, but his motion is redundant, and certainly those points are already, many of those points are already.
No, they're not.
Order. Excuse me, you're out of order, ma'am. I have the right to give my opinion, do I not?
Okay.
I would call for the question at this point.
Well, Julie Malika still has.
Julie hasn't gone. One more, Julie, please.
No additional comments. I feel like everyone covered it.
Okay. Kevin, did you want to make one final statement?
Yes. So appreciate the comment. This is my first time on a health board. Just for your edification. Not that it should matter. So yeah, I think the intent of the motion was to make sure that there was a review in place and required, and that was the intent of it. This language is very loose, unless amended, extended, or rescinded, and the intent was to force that activity to happen. And it sounds like Dr. Douglas and team is going to be reviewing consistently. Perhaps it's redundant, but I would feel better if it was stated in the motion.
That's fine. Your motion is on the floor. Linda, you seconded. Do you have a comment?
Yes, I think that this motion is not well written, because although it talks about amended, extended, or rescinded, it does not give the parameters for that. There is nothing in this motion that says we have any endpoint whatsoever or any objective review. So I would actually say that Kevin made a very valid point.
Okay, thank you. Renee, do you, I think it's time for us to vote. Would you call the roll call and ask people whether they want to vote for or against this motion?
Absolutely. Representing Adams County, Julie Mollica,
No, I do not support the motion.
Rosanna Reyes,
No, I do not support this motion.
Julie Schills.
No.
Representing Arapahoe County, Jan Brainerd.
No, I do not support it as stated.
Dr. Thomas Faywell,
No,
Dr. Kaya Gallagher,
No.
representing Douglas County, Kevin Bracken,
Yes, please.
and Dr. Linda Fielding.
Yes, please.
And as stated previously, Kim Muramoto is not present at this meeting.
Thank you. Well, thank you, Kevin, for bringing up the motion. I think we all are in spirit with you, whether it's explicit, how frequently or with what metrics. The Board of Health I can assure you, will continue to be talking about this as we move forward. The motion did not pass, 6 votes against and 2 votes for. So at this point, do I have a motion to adjourn? I know we're going to be getting together again soon.
So moved.
Is there a second?
Second.
Second.
All in favor, just say aye.
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 Anybody opposed? Thank you very much. I'll see you soon. We'll talk with the attorney. We'll set up an executive session. Thank you, Dr. Fielding, for your motion. And, if you want to state the motion or you want to write a motion, please send that to me. Thank you.